Hi, everybody. It's Sue here, and I'm gonna keep this Sunday afternoon conversation a little bit short because I'm kind of losing my mind. How are you guys doing? I expect that through the next short time that we're in conversation here, you'll be hearing children running and probably calling me, and my mom asking me to get her something, and my dog barking crazily. And I really apologize for the less than ideal recording, but maybe it's a little bit of life. So if you can hang in with me, I want to talk about something really serious, and I hope that the volume is okay for you and that we can manage to get through a few minutes with some calm here. Today I want to talk about, so it's January 24th. We're heading into week 3. We've done vital signs and really looked at those in an intensive way. We've also done ABGs. No, we did fluid and electrolytes. Yikes, I'll see already because my daughter's here distracting me. We've done fluid and electrolytes in a basic way, and we're moving into Nashmatsa iced tea boxes. Now we're moving into ABGs this week. So you'll have lots of opportunity to review that. I know students always say that they have learned about ABGs, but I'd really like us to focus a little more deeply. So there'll be a PowerPoint that you're going to see that is an overview of basic interpretation of ABGs, a really important interpretation. But then I want to really give you some case studies in a separate opportunity to look at and work on, because it's the clinical context that matters. So you have to know how to interpret ABGs, and that's great, but how to interpret ABGs within the context of your patient is what matters. And so we're going to work on that as well. But for this short conversation, what I really wanted to talk about is a topic that's just so near and dear to my heart, and I know for Leslie the same, and it is dignity in undignified circumstances. A good example of that is for any of you who've had the opportunity to participate last year in the opioid overdose SIMS, looking after people who may be present in all kinds of situations, not having the best control of themselves. People may not be dressed. People may be having, vomited, lost control of their urine or their bowel, or their ability to hold their urine or hold their stool. And so they may be presenting in a way that in other circumstances we would turn away from, right? And recognizing how very important it is that we don't. And there's a couple of stories I want to tell. One is a very dear friend who was looking after a man one night who lived on the streets. It's really important. One of the fundamentals you're going to learn if you ever work in the emergency department, if you're working in community, if you're with street nursing, it's so important. For people who are living on the streets, their feet are critical. So we pay attention to that, right? So we would be concerned about anyone who has an ulcer, blisters that might turn to an ulceration or some kind of an infection. Someone who's living on the street, though, may not have the opportunity to have clean water to wash something with, to be able to get medical supplies if you want to put a dressing on or something like that. May not have the funds to be able to buy medication, even something like polysporin, before a blister and a small ulceration becomes really catastrophic. They may be exposed to the elements, and in particular, cold winter can lead to really significant problems. We know that many people living on the streets may have issues with substance abuse. One of the things that alcohol does is it sort of shunts blood a little bit to your core. And so your peripheries, it helps in that process that you don't notice. Your peripheries are getting less blood flow with the cold, right? So cold has the same effect. So you are at high risk for frostbite in fingertips and in toes. We also know that there are a large percentage of people who are living on the streets have diabetes, not well controlled. Again, we're looking at lots of circumstances associated with that. Anyways, to the point, a friend of mine was working one night and she had a patient who was brought in. He had, I think, a seizure and was found on the street and brought in. He was a First Nations gentleman, Indigenous person who had, when they undressed him and took his boots off and then his socks off, a couple of his toes actually came off in his sock. They had been so frostbitten that they just came off. and it wasn't like this was some, massive incident with bleeding and other things. He had some gangrene that had set in, and he had maggots. So he had maggots that were on his, they had gone into his boots, and they were living on the dead tissue. So there's ups and downs of maggots. We know that in the old days, they used to use maggots as part of medical treatment. And we know now in the new days, they use maggots as part of medical treatment. So sometimes if you're working in a place, a modern hospital, not somewhere with, in an underdeveloped country, but in a modern hospital, what maggots do is they eat the decaying tissue. Right, so they're not interested in healthy, well-nourished tissue. They eat away at that decaying tissue. And so they have medicinal purpose, but I don't know, they're not something that I would like to work with. I just don't really like them. I think most of us have kind of that kind of reaction. So my friend Andres, this gentleman, she had to, one of the things that the doctor ordered was that they had to remove all of the maggots from both feet. And that's a yucky process, right? It's kind of a yucky process. The gentleman had not had anything to eat for several days. He was now awake. She brought him in a couple of sandwiches, a couple of those small juices. And as she was in his room, trying to just talk to him, right? It's hard not to be in the room saying some, like having a look on your face, expressing in some nonverbal way, or even in the way you ask questions. How did this happen to you? Did you know that you had maggots on your feet? You don't have to say things like that. And there's ways to be more delicate about it. And remember, human dignity, right? Just because he's in those circumstances doesn't mean he doesn't get the same, deserve the same level of courtesy and dignified interaction as anyone else. And so as she was removing his maggots, he offered her some juice in a sandwich. And you might say, oh, yuck. Here's this gentleman, and here's his circumstances, and he's offering it. This is a gentleman who has been on the streets, and he hasn't eaten in days. And his circumstances are really rough. And the first time he gets something to eat, he offers to share it. It's so important to recognize the humanness of the human being with whom we are reacting. So a couple of points that are just really important to me. Dignity and treatment, dignity, preservation, and promotion of human dignity, for me, are at the very core of what we do as nurses, at the very core. Saving lives is part of what we do, and enabling persons to die with dignity is part of what we do. But at the very core of nursing, if you ask me in one sentence to describe what nursing it is the promotion and preservation of human dignity. And so for me, just a couple of points here, that dignity is a right. It's not a privilege. No matter how a patient is treating you, treating them with dignity is a right that they have. And that is clearly delineated in the CNO standards. And that it's really your greatest calling. It is your greatest calling, and it sometimes can be your greatest challenge. It's okay to be a human being and process what's happening. It's not always easy to treat someone with dignity when let's say a patient might have a substance abuse problem or a mental health problem, and they are angry or disinhibited, and they may be treating you verbally, hopefully not physically, but verbally, in a way that would be not acceptable. When I was a young nursing student, the best of de-escalation that we learned would be to say that that's not appropriate, stop saying that. We are now much more finessed about that. And it's not, the message of that's not appropriate is an important one, but often now we are much more finessed in de-escalating about trying to get to the core of why someone is behaving a certain way. Sometimes if it's substance abuse or other things, it's not really about trying to understand at a deep, mental health level what's going on. It really is that disinhibition from substance. In other cases, it can be how how a person is interpreting the moment within the context of their perceptions and their life experiences. So it can be hard because we're still human beings. It's okay to process that. It's okay to process what's happening. I remember working with a nurse who had a patient with who was being admitted from a mental health crisis, and that patient unfortunately was restrained, and was being admitted to the mental health unit, mental health floor, and there was not a bed. And the entire night, the patient just kept yelling out to her, calling her fat and ugly. Yeah, I want the fat and ugly nurse. You're the fat and ugly nurse. Oh my God, you're so fat and ugly. And I remember the first thing when I came in to get report the next morning, I said, how are you? She said, I'm fat and ugly. And she wasn't saying it in a funny way. She was just saying it in a kind of, I feel defeated. And she'll be okay. She's going to go home. She's going to have some breakfast. She's going to brush it off. But it is okay to be a human being, right? And I think when we deny that we're a human being, it becomes very hard to reach across from my vulnerability to your vulnerability, which is at the core of nursing. But preservation of human dignity is always within your power. So I can't I necessarily control the circumstances. I can control how I respond to them, and I can have an impact on how the team responds to them, and I can intervene when there's inappropriate behavior by any other member of the team. That is my responsibility by CNO standards as well. So it's not just my own behavior, but it's the behavior of the team. And I'm going to give another example. A dear friend of mine once was changing a patient. So it was a very elderly man, but he was with it. And he was being seen in the emergency department for, you know what, I can't even remember why, but he was wearing an attends kind of brief. He'd had bowel movement and she was going to change him. And she had another nurse helping to turn him. And as she was turning him, he started to have a very, like a loose stool. And just the way she was turning him and where her hand was when this happened unexpectedly, the stool actually started going into her glove. So the stool was between her glove and her hand, holding all the stool in and going around all her fingers and under, like everywhere. And the gentleman said something like, oh my God, I'm sorry, are you okay? And she said, absolutely, there's nothing back here to worry about. You just carry on and I'll carry on. And was able to say to her friend, can you just maintain, hold this patient for just a moment. And, very quietly, without making a fuss, took off her gloves, washed her hands well, put on a new pair of gloves and carried on. So she didn't need to say to him, oh my God, or say to her colleague, oh my God, this is terrible. She was able to just move on as if it was nothing. That is so critically important. When patients say, I'm so sorry, when they're having a bowel movement or something. When I worked in GI surgery, a specialized GI surgery, we used to say, oh my gosh, that's so fantastic. Nothing that like I was waiting for you to have a bowel movement. This is success. Let's have a celebration. So the way a body works is not something that should impact someone's dignity, right? Because we can maintain dignity. If somebody is arrives, let's say, with no clothes on or partially dressed or other things, even in the midst of a code, we pull curtains if it's possible to pull curtains. We don't leave people to be exposed. We don't allow a whole bunch of looky-loos to come on as we've got, let's say, a code happening or a pre-rest or something else. We always would say if the only people who are allowed to be in the situation are the people who need to be in the situation. Sometimes a student might be observing, or an RT student, something like that, a nursing student, but always we are maintaining dignity. Our first thought is around dignity. And it really is important that you understand that dignity is not just something that you promote within your own self and your own practice, but it's around the culture of the healthcare team, that this is something all of us work towards. We don't make negative comments about patients. We don't make some, this is a sort of a common terrible one. When someone is mentally ill, have you ever seen people do this? We don't do things like that, right? We don't ever do things like that. And we don't roll our eyes. We just carry on, right? Because we see people sometimes at the hardest moments they may be experiencing. And we are always making sure that they are treated with the utmost care and compassion and dignity. And so we need to see that within that team. We need to see that within the unit that we work on, and you'll see that that can vary, and our presence can make a big difference, but also setting limits on what is acceptable can make a big difference. And within the organization, what is the standard within the organization? And for most of us, failure to maintain that dignity can lead to something called moral distress. And I know you learn about this in a variety of different places in your program, but that idea of when either you don't know what, you can't figure out what the right thing to do is in a certain situation, or you know what the right thing to do is, but you don't feel empowered or able to act on that, can lead to a situation where you just feel so trapped. You feel as a human being so incredibly trapped. And often one of two things happens. You shut down, and you shut down your emotional side. So you just kind of go through the motions. You end up denying that part of you more and more in your practice. And you're just, you're just the person in the uniform. You're not yourself fully. And we know that leads to very catastrophic experiences for nurses as they move through their careers. That's hard work, putting on that mask all the time. The other thing it leads to is the nurses leaving their profession. It's too much, it's too hard. It just becomes too painful to work. So that idea is within this work environment, do I feel that I'm enabled to provide the kind of care that I expect all patients deserve? And to hold that line is really critical. And so one of your student colleagues sent me this example. I'm sure many of you have seen it by now. I want to talk us through it a little bit, and then you can watch that short video, read the story. It's the story, it actually happened a couple of years ago, but it's new in the news, of a patient who had a mental health history of bipolar disorder, went to the emergency department because for about 30 days or so, he'd been noticing increased difficulty in walking and terrible pain in his legs. He was seen in the emergency department. He had a workup, including an MRI, which was great, and found nothing obvious. They then referred him, because he was just complaining of this excruciating pain, they referred him to psychiatry, wondering if this was a manifestation of his bipolar disorder. Psychiatry came and saw him and said there was no reason for them to admit him. Now, here is the thing that we need to come back to. You've got the medical doctor in the emergency department saying, I'm not seeing anything. You've got the psychiatrist saying, well, this is not about his bipolar disorder. But he still has that pain. So both of them saying, I don't see anything, does not make that pain or that inability to walk go away, right? And yet the determination was made that they should discharge him. Now, it seems kind of, in retrospect, so suspect that people would follow through on this. But in any case, the patient was discharged, and it took the patient 30 minutes to get from the stretcher to the front door because he couldn't walk. And at one point he was crawling on all fours on the ground in unbearable pain, and he just couldn't walk. And there was a nurse who at one point was trying to get him out. And I don't know how this happened. I don't even know. Imagine the spectacle of this, right? He's in the hallway of the hospital, and he's just crying out in excruciating pain. And the nurse is saying to him, you're a big boy now, come on, be a big boy. First of all, I don't even understand that. I wouldn't even say that to a child. Usually for children, this course is about adults, not children. Usually for children, what you would say is you do whatever you need to get through this, right? So I wouldn't say be a big boy as I take blood on a 5-year-old. I wouldn't say to a grown man in excruciating pain, you're a big boy. First of all, unbelievably offensive. Secondly, why are you helping him to get out like this? Taking half an hour, like, are you? So if you're thinking that this is, he doesn't have real pain, so you're doubting he doesn't have real pain because the MRI showed that everything seemed to be okay. But then the psychiatrist said this is not about his bipolar disorder. Why are you saying, okay, so we don't have any answers and we're just going to send you out? Right? Like, so you think he's just like pretending? But if he was pretending or faking, wouldn't that be part of the psychiatric assessment? Right? Wouldn't they have said, well, if he's faking to such a degree, then that maybe this is some kind of mental health crisis. Like, so for me, the thinking doesn't make any sense. And so they helped him out, even outside then for 30 minutes in excruciating pain, unable to walk even at points on the ground. And then a security guard helped him to get into a cab. And they told him there was nothing wrong. So he went home, and after a couple more days, finally he went to CAMH thinking, okay, well, they said maybe it's in his head. It's about his, is this about his mental illness? And the doctor at CAMH right away said, like, this is not about your bipolar disorder. Sent him to Toronto Western, which has an incredibly good reputation for their work with patients with neurological disorders. And immediately they were able to recognize that this patient had Guillain-Barré syndrome. And so in Guillain-Barré, it is often it's follows some kind of impact, something that would impact your immune system. So a viral impact post immunization. Sometimes you'll see it post flu shot and other things. Where you have an increasing paralysis that moves up your body from your feet, up. Patients with Guillain-Barré are often required to be intubated because that paralysis moves up their body so much that their diaphragm is affected. They are not able to maintain their own respiratory process. It is a life-threatening diagnosis. And so here is this man who has gone through all of this and has a misdiagnosis. Now, misdiagnosis happens, right? It's unfortunate, and we do our very best all the time to do our very best. And one day someone will say to you, remember that patient, and nothing good ever follows that expression, remember that patient. But that's why we do our best, right? That's why we always do our best. In this circumstance, it doesn't seem as though anyone was doing their best as you were letting him crawl out of the hospital for 30 minutes. And so for me, this is such a failure of the entire system. And then there was a 2-year process where he tried to get the film. They wouldn't give him the film. He had to go to court, other things. But I think this is important for us to watch because in high acuity areas, often we are faced with this. Patients who are intubated and ventilated and are sedated and paralyzed are still human beings. So even though they're sedated and paralyzed, we would still inform them of absolutely everything I'm going to do. Whether you call a patient by their formal name, Mrs. Johansson, or Jane, their first name, you would still say, hi, Jane, it's Sue, I'm here again today. I'm going to be looking after you today, and I'm going to help you to clean up here in a minute, and blah, blah, blah. You would still talk to that person as a human being, regardless of the fact that they are intubated, ventilated, sedated, and paralyzed, because they are a human being, and that's part of your practice. In the emergency department, we'll see people who are not at their best. So there's no reason to tell somebody that they don't smell good, or that, other things. That is cause to say, let me see if we have any clothes for you, because always in the emergency department, you're going to find extra clothes. They have usually a storage social worker can help you with that, of some extra clothes, donated clothes, that you could try to help replace what the person may have lost or what may not be wearable anymore. When we're thinking of cutting off clothes, right? It's an emergency, we're trying to cut off clothes. We do that as little as possible because, I have no idea how valuable something is to a person. That shirt may have been the last thing a person's mother gave them before she died. I just don't know anything. So we do that as little as possible, although we do try to save lives and we need to have access to a patient. But keeping in mind, dignity does not fall away just because a person is so incredibly vulnerable and because we are seeing them in a situation that may be imperfect. So regardless of how undignified the situation is, we never compromise on dignity. And I think that's kind of my last word on that. And I hope that didn't sound preachy, and I hope it's just something to plant, a seed to plant. And I know for many of you already in your practice, so in your student nursing practice, for some of you, you're working as PSWs. I know you bring that to your PSW experiences. And for those of you who are RPNs, I know you bring that to your practice, but I know you also see it in other situations. So where it may not be ideal, even if you're bringing that to your practice, it may be that situations are happening that are not ideal. It's not just one doctor and one nurse, or 2 doctors, mental health doctor and emergency doctor and one nurse involved in this situation. How many people saw this happening for half an hour? And at what point do you say, this is not working, right? There's something wrong. with what's happening here. And I think that I would never say that that's easy, but I would say it's essential. That's what, those are the stakes. That's how we have to do it. And that's why the public trusts us. They trust us to do what's right, even when sometimes that can be a struggle. Okay, well, that's enough for today. I sure hope you were able to hear me above the din in my house. I sure hope you're doing well. I think about you all the time, and I know everybody is going through a lot. And I'm missing seeing your faces, but I am enjoying very much the opportunity to go through some of these topics, and really loving the opportunity to talk to you a little bit more informally on these Sundays. All right, enough for now, and I'll be back.